first off, I want to say to everybody there, welcome, okay? Welcome to Getting Familiar with Telehealth, all right? And we're here today with my doctor, Dr. Aaron Boster, and myself. So I'm the MS patient, all right? And again, as I was saying, I am an MS patient, so I get to do this realistically, all right? And I just want everybody to know, though, that I do have a doctor, another doctor, a primary neurologist of mine, and he's in South Florida. His name is Dr. Aaron, excuse me, his name is not Dr. Aaron Boster. His name is Dr. Brian Steingo, all right? And Dr. Steingo is totally aware of everything that I'm going to be discussing with Dr. Boster, because I also have the two of them spin things off of each other at times when they can't figure out what's wrong with me. But just so you all know, I have my notes. I'm not showing you my notes, but I have my notes, all right? It's 2 pages of notes, all right, that I have here for what I do when I go for a medical appointment. Is I write everything out in advance, all right, and I bring it in with me. And there are even times that, I mean, I could be showing up for my appointment if it was real, you know, and I'm going somewhere. But even on telehealth, when I'm about to get started, I'm looking at everything and I'm saying, wow, how did I forget this? Well, how did I forget? Easily. I don't remember crap, okay? That's what goes on with me, all right?
You know, on the flip side, Stuart, as we're talking about getting ready, in preparation for a given clinic visit, I do homework. So I will read through my last couple notes with you to see where we were, what our plans were. It gives me my items that I want to discuss. I also will grab any old labs and I'll look through a couple of your old MRIs. So I also am getting myself prepared to engage in the conversation. You know, it's been my experience that if patients don't do what you just said, to take notes, we don't get as much out of the interaction. So I want to highlight that as being something really, really important.
Absolutely. Thank you. And so let me get started, all right? I mean, first off, for anybody see me with a tissue, it's not that I have a cold, but it's chilly in the studio, all right? And again, I'm just not used to waking up to 35-degree temperature, which it was this morning. Unfortunately, I had my puff coat with me, all right? And yeah, I'm actually in Florida, but I'm not in South Florida where I live. So I'm in North Central Florida, and it is chilly here. All right, so getting started, though, with my medical appointment. Doctor, thank you for seeing me today. How are you doing?
Great to see you again. How you been?
I've been well, thank you. I've been fortunate.
Now, so, being well, like you're being polite and socially polite, or being well like you're actually doing well right now?
I guess that I'm socially correct with staying away from groups of people, you know, staying out of where COVID could get to me, because sure. I want to live and I want to do well, and I have to be able to do what I do in life, and so I don't want to get sick. And I know too many people that have gotten COVID, some asymptomatic. I unfortunately know people that have died. In fact, I got a message yesterday from my brother-in-law that somebody that I know from up north in the New York area passed away this week. He had COPD, but he passed away from COVID. So
it's a really scary time. You know, we are not immune to that here at our clinic, and we've had several patients be in the hospital, several in the ICU. We've had 3 patients pass. It's a travesty. You know, I have my list of things that I'm excited to go over with you today, but I thought we would start with your list and then we'll double back to my stuff. So what's on the docket that we want to make sure that we're talking about today?
That's great, but I also want to let everybody know that it's not just about me this morning or about Dr. Boster, all right? It's about this program and what we're doing. But if anybody has any questions based on this type of program that we're doing on telehealth, all right, if you have questions about this and only this, we're not here to talk about COVID and we're not here to talk about medications. So please don't bring up those questions because I'm not going to ask them. But after I do my whole telehealth appointment with Dr. Boster, then we're going to take questions from the audience as well. Okay. All right. So let me just get started. All right. I'm here. I got issues, Doc.
Tell me where you want to start. Let's discuss the things that are on your list, and then we'll double back and do some of the stuff that I have written down.
All right. So the trigeminal neuralgia continues. I mean, there are times that it is very mild. You know, like I'll get a pain and it's there. It's only on this side of my face. I'll get a pain. It's there. It's gone almost as quick as I could say, ouch, it's gone, you know, but sometimes it's a prolonging pain where it stays there for a good 20 seconds and I can assimilate it with of people that may be in an earthquake, all right? Sometimes it's short and brief, and sometimes it's long, and it's terrifying. And there are times, though, that the pain is so bad that I want to stand in front of a freight train.
Sure. So trigeminal neuralgia, as you're well aware, is one of the most severe pains that a human being can experience, Stu. And I guess let me ask you a couple questions. How many times in a week, how many days in a week might you experience that?
It's more like maybe just once or twice a month rather than days in a week.
Is there a trigger that you've identified? You say, like, if I miss sleep, or if it's cold outside, or if I eat something, you don't notice anything that seems to trigger it?
No, I'm not noticing any of that.
And the pain when it occurs, is there anything that you found that will intensify it when it's occurring, or it's so brief you don't even have time to sort that?
So again, most of the times it's just short stabs, like somebody's taking a pick and jabbing it into the side of my face somewhere. But there are times that I've noticed that even with the Trigem, that I'm getting like a little Bell's palsy.
Yeah.
And I don't know if it's associated or not.
It's sometimes nature's too generous, and it can be two separate. I'm going to focus on this pain for just a quick second. You know, I don't want you to have that pain, and I want to talk through a couple different things that we could consider. Now, if we think about options, let's discuss all the way from super laissez-faire all the way to the most aggressive conservative thing we can. All right, so we're going to kind of do a gambit. We could do nothing. Why could we do nothing? Because treating the trigeminal neuralgia or not treating it isn't going to slow down or speed up your MS. Now, I'm not voting to do nothing because I do not like that pain for you. I'm simply saying that in the hierarchy of needs, that's an option. It's not the one I'm going to recommend. So if we scoot over here, we start to get into therapies. And there's really two kinds of therapies when we're dealing with pain like this. So we have something to try to address the pain when it occurs, and then something to prevent it from happening. Now, the problem, as you describe it, is this doesn't happen very often, and it doesn't last very long. So let's pretend I gave you a medicine and you carry a pill in your pocket and you have the pain. By the time you fish the pill out of your pocket, swallow the pill, wait the 20 minutes for it to kick in, the pain's been gone for half an hour.
That's right.
And so that's a problem. The best way, in my experience, to address it, if we want to try to use a medicine, Stuart, is to give yourself something that you take on a regular basis. We call it a prophylaxis to prevent it from occurring. And, you know, it's really a risk benefit. How much do you want to take a medicine on a regular basis to prevent that from happening? If you tell me it's not that big of a deal, Aaron, I don't want to take a medicine on a regular basis, I respect that. But if you're willing, then the idea would be that instead of a couple times a month, that it doesn't happen at all. What is your sense there? Is it something that you'd want to consider medicine for?
No, but I was saying that there are those days that it's repetitive during the course of a day. And for that, you know, if I find that it's happening 2 or 3 times, I know it's going to be one of those days. Yep. And what happens is during that day, it may start off as short stabs, but then it intensifies. Yeah, it's like an explosion happening to the side of my face. And that's when I want to find, first off, it can last for more than a day also. And I find that in day 2 of having to live that, I don't want to live that. Yeah. So that would be a great time to have something.
So 2 things that I would say. Thing number 1 is, if this is happening, you know, particularly if you have a day where it's like the second day it's going on, reach out. I mean, reach out to Dr. Stein, reach out to me, you know, let us try to intervene. All right. So that's the first thing. And when I say that, I really mean it. I mean, you know, you have my cell, you can text me or you can call us because we can help in the now. The second thing is, it might be valuable for us to make sure you have something that you can take, not for the one-time one and done, but for when you're noticing there's a pattern and you're thinking, man, this is going to go on for more than just once. And so maybe we can talk about some options there. Now, most of the medicines that we use are actually invented for other purposes. So they're like seizure medicines or depression medicines, and we're not using them for either purpose for this. We're using it to treat the pain. Why does it work? Because a lot of those medicines, they work by stabilizing cell membranes. For example, a seizure medicine, you know, you're stabilizing cell membranes so you don't have electrical storm on the brain. Well, that's kind of what's happening with your trigeminal nerve. So we could provide a medicine like Tegretol, carbamazepine. There's newer versions, Oxcarb, Trileptal. I've had good success with those. We can use Neurontin or Lyrica. the thing that we have to keep in mind is normally, Stu, we want to take that a couple times a day to build a blood level. And because you're not going to be on it and you're going to take it only when you're in an acute bout of pain, the way to circumvent that is to take a pretty hefty dose as long as you're ready to be a little bit sedated. You know what I mean? So you can't be driving across Florida and taking high dose Neurontin for the first time that day just because it might make you a little loopy. Something else which is maybe a little bit contentious but is extremely effective is to use medical marijuana. And so I don't know if you want to kind of consider that as an option, but I'll be honest with you. I've had a lot of success using, for example, a fast-acting cannabinoid to help stop trigeminal neuralgia pain. I've done that a couple times this past month. Is that something that you want to consider or talk about?
So I do have a cannabis card. It is doable. I mean, I personally don't like getting high, but I do like to do it just to get rid of pain. And I do use the cannabis for other pain in my body. I get a lot of the paroxysmal pains, which I don't talk about because the more I talk about it, the more I'll start feeling about it again. So
let's not do that. So, you know,
right.
If you think about, let's just talk for a couple minutes about medical marijuana and using cannabis to treat pain.
Sure.
Because in my practice, I've had some good success with that. We could alternatively be talking about Tegretol or Neurontin, but let's just talk about cannabinoids for a second. So there's the one thing I don't want you to do is I don't want you to light cannabis on fire and then breathe in the smoke, just because I think that's pretty pro-inflammatory. I want to look for other ways of fast acting, right? So a vape pen is a very effective way of doing that. So a vape pen looks like a pen. This is not a vape pen, this is a pen. And it's got liquid concentrated THC and CBD. And when you pull on it, you're heating it up below the level of combustion. So we're not lighting it on fire and you're not breathing in smoke, you're breathing in vapor. But when you look at the way that it is absorbed in the body, it's very quick. It's almost as fast as smoking. So I have some patients, they'll use a vape pen, but there's a problem. And I need to ask, does it hurt when you move your mouth when the pain is bad? Because some people, they can't move their mouth. So that's okay.
No, I don't have it like that. In other words, I can say ouch.
Okay.
You know,
I have some patients, they won't move their mouth. They'll literally like drool. They won't move their face at all because it hurts too bad.
I can understand that.
They don't use a vape pen because sucking on it hurts. And in that case, we use tincture. Tincture is a really old pharmacology term, right? It's like a liquid dropper, and you can put the liquid under your tongue and it's quickly absorbed. So if you had either a vape pen at the ready or tincture, and you noticed, hey, this is starting to trigger, then you could use that to try to break the pain. In the same way that you,
about the vape pen, isn't that like a couple of years ago when they were having so many problems with the vaping? I mean, that's been my concern, why not to vape,
So if I was choosing for you, I'm gonna use tincture, because a vape pen, you're still breathing in some stuff into your lungs. And to your point, I don't know 100% what's in that stuff. A lot of the bad press surrounding vaping was surrounding some specific products with tobacco vaping. These Juul things that were being sold to children because they had things in them that weren't just, tobacco. And so it's my hope that if we're dealing with a cannabis vape pen, we have a little bit more security about what's in it. That being said, if there's concern for whatever reason, I have patients that just don't want to breathe something in like that. A tincture is an outstanding way of administering cannabis really, really quickly.
Gotcha. I don't want to take up too much of your time just on that because I do have a lot of other things going on.
Let's do it this way. Do me a favor, and over the next month or two, chart when you're having. Just put a check mark on your calendar, and that way, the next time we talk, we can go back and look just to kind of see the frequency. Try, if you have a vape pen, let's make that our primary plan and try it, and then you give me some feedback and say, Aaron, that's not working. Okay. If that's not successful, then we may end up talking about keeping some Neurontin or Tegretol in your pocket for those really bad situations. But let's kind of look at it, and then we'll double back in a month or two.
Sure, we could definitely do that. It's easy to tell, though, because a lot of times I throw darts at the wall every time I have all that pain. I have a spot on there. It says no pain, and I throw a dart at it.
Nice.
No pain, right. All right, so something that's been really, really strange and happening with me lately, and aside from a lot of processing problems, which I tend to have on a regular basis, and I just, try to combat it as best I can, is that I'm getting honked at a lot at a traffic light, and I realized why. that I see the light turn green, but I don't know to step on the gas.
Are you noticing things like that outside of driving?
Yes.
Can you give me another example outside of driving?
I turn on the laptop and I don't realize that the screen is on already, or that if I'm listening to something, I'm missing the first several words because I'm just not like totally focused on. I see that it's on, but I'm not in it.
So Stu, you're describing cognitive issues in MS rather eloquently, because the biggest issue with thinking and memory in MS is attention. So this is not remotely related to like Alzheimer's, dementia. It's not a situation where someone doesn't know who they are. You're having trouble locking on. And you just said it very well when you say you missed the first couple words because you're not attending. And it's not that you're not looking or trying, it's that MS makes it hard to attend to what's going on. So immediately my thoughts come to energy conservation and fatigue, because this is a form of fatigue. This is cognitive fatigue and problems with attention. So my first question is, how much are you sleeping? Because if I sleep deprive someone, I can exacerbate this. So are we getting a good solid 8?
No, well, I never got 8. Okay. So wait, but I'm doing more than I was doing.
Tell me about it.
Until just a few months ago, I was very content with 4 and 5 per night. And now I'm finding 6 and 7 are best.
Okay. So I want to highlight the fact that if you're sleep deprived, any issues with attention that you have are going to be exacerbated. So just pay attention in the back of your head, how many hours am I actually getting? And if you're noticing that you're kind of, it's getting too low, you may need to dock some more hours of sleep. Along the same lines, do you ever have occasion to take a quick nap during the day? Like, does that ever happen?
Yeah, like a power nap consists of 12 minutes of downtime.
Okay, well,
that's the reason.
But the reason
I wake up automatically after 12 minutes. So,
but the reason that can be helpful is sometimes you can reset your battery, and taking 15-minute, 30-minute nap. If you can learn to do that, you can find that the second half of your day with MS, you're much more attentive to what's going on. It's kind of like a powerful tool.
Yeah, it is. It definitely, that 12 minutes does make a big difference. Now, if I go to 30, I feel drugged when I get up from it.
Got it. So I like that you're doing that. Now, the most common symptom in MS is fatigue. And one of the biggest issues that create problems in the workforce, for example, is a combination of fatigue and the attention problem that you're describing. And a lot of times we have lotions and potions to help with that. Now, I know you're not a big fan of taking medicines, but have you ever considered taking a stimulant? Have you ever been on a stimulant yet?
Only when I did bad stuff many years ago.
Yeah, so I'm talking about using like Provigil, Nuvigil, Adderall, Ritalin. These are medicines that can trick your brain into being more awake, and they can make a profound difference in your ability to attend. They're medicines that you don't have to take on the daily. In fact, I don't want you to take them on the daily, but if you are willing to try one, the experiment that we would do, you're not an experiment, but the experiment that we would try is take one when you wake up and see what that day is like. See if you notice you're more attentive when someone's talking to you, you notice the light quicker, whether some of that stuff is better. I suspect that you'll notice a difference when you use a stimulant.
I can definitely look at that. I'm making a note about that because that's something that now I have interest in. By the way, you all should make notes too. If you're on a telehealth call, you should make notes about things.
And just to talk about that, as we talk, I take notes on my computer. So I'm documenting that we had this conversation. That way, even if we don't choose to do a stimulant, next time I meet with you, I have it written down that we talked about it, and it lets me just follow up.
Sure. But I forgot that I'm on a call that's going to be on my YouTube channel, and I don't need to make notes.
Yeah, we can just go back.
Right. But in general.
Talk a little bit about stimulants. I find no matter what flavor we're using, that if you never take a break, they can start to wear off in their benefit. So at best, I want you to use it 6 days out of 7. I want you to at least take one lazy day off a week. Ideally, we're not going to use it every day. You're just going to use it on days when you really need to mobilize.
So isn't that the same as like just ODing on coffee?
It is, but it can be more effective. So, I mean, I'm a big fan of coffee, and caffeine can help trick your brain into being awake. But it's been my experience that some people, when they have very mild issues with fatigue or with cog fog, coffee will work. Sometimes it's a bit more than that. Or sometimes you don't want to be drinking 2 gallons of coffee trying to keep yourself awake and peeing. And so being able to have a pill in your pocket when you need it, there's an advantage there. Side effect wise, just things to think about. These medicines, these class of medicines can worsen headaches. And so we have to think about that. Sometimes they can make it hard to sleep, which is why I like to dose it first thing in the morning.
Well, that's why I go back to the coffee again, because the coffee I use is a stimulant, and we use that to get rid of headaches. So it's a dual effect, right?
Absolutely. It's just something I want you to think about. In the meantime, while you're considering a stimulant, let me throw out another idea. Have you ever taken levocarnitine or L-carnitor?
No.
Levocarnitine is an amino acid. I mean, so it's safe. You know, it's something you can pick up over the counter. A gram twice a day was studied in MS, and it actually beat in a head-to-head challenge a known MS medicine for fatigue. There's an old medicine called amantadine that I don't find a lot of success with, and they pitted it against levocarnitine. Levocarnitine won. And so, you know, taking a gram twice a day is a very safe thing to do. And in my experience, sometimes that actually helps with energy as well. So as you're thinking about whether or not you want to consider a stimulant, you might try that out for a month and just see what you get out of it.
Is that accessible from a regular pharmacy, or do you have to go to specialty pharmacy?
No. You can pick it up at any place that sells health food stuff, vitamins, minerals. It's just an amino acid.
Well, that's great. You'll have to write me a script for that.
All right. So I'll give you the name of it.
Okay, cool.
What else? So
yeah, exactly. I got 1, 2, 3, 4 more things that I think are important. All right. You know, you would think that Stuart Scott, you know, like the world by the horns. I shouldn't say that after watching that guy on the TV the other day, though. But you know, I do get my doldrums. I do get. I don't know if they're because I'm looking at, you know, my age, my years ahead are much less than my years behind at this point in time. I could think of that. I don't think that I get the doldrums from medication because I don't do enough of any medication to say that. But I just wake up that way, and there are days that I just say, "Why am I doing what I'm doing?" And you know, and then I hear, "Well, you know, Stuart, you're doing so much for the community. You know, you got to keep on, you know, doing what you do. We need you like that." Yeah, but I need somebody to help me get through those days. And
so you know, the people impacted by MS are twice as likely to experience a bout of depression compared to the general population. So the deck is stacked against us with as it relates to mood. Moreover, you know, there's a global viral pandemic, and to say that has an impact on mood is a gross understatement. Moreover, I know you, and you are happiest when you're traveling, and right now you're really not afforded the opportunity to travel. And so if you told me that you weren't feeling a little bit dysthymic or a little bit blue, I would actually view that as weird. I think unfortunately it's appropriate. And I also want to point out that it takes a big man to say, "Hey, I'm not feeling awesome." A lot of guys, I'll work with them for years and they're never comfortable sharing. You know, I've told you before, I have depression. I take medicine, I see counselors, and it helps a great deal. So let's talk through some options for things that we might want to explore. And I'm going to list a bunch of stuff, Stu, and you tell me which things kind of resonate with you, right? So one thing that has been found time and time again to be very, very valuable or helpful in managing mood is to talk to a trained listener who's not your loved one. So if you tell your loved one that you feel sad, they feel an emotion.
My loved one is definitely not a trained listener.
Well, no loved one is. We're intimate, and so it's not objective. And as a result, even though they love us, they can't help us find those aha moments. And so if you talk to a trained listener, rabbi, priest, pastor, social worker, psychologist, like whatever, you talk to one of these people and you connect with them and you say, "Hey, I feel sad." They say, "Tell me about that." And they lean in and they listen and they help you process. Now, some people would rather be jumped into a gang than talk to a counselor. But I want to point out that in the COVID era, counselors have made themselves available on telemedicine. And so I would challenge you to consider trying to connect with someone. Now, one comment about that is you have to like the counselor. If you don't enjoy talking to them, they could give you, quote, the answer, and it won't resonate. So you really have to kind of enjoy the interaction. And so I'll toss that out as something for us to consider. A second thing, which again has been shown to be very, very helpful, is group therapy. And you and I both are involved in social media, but I'm talking about something rather different. I'm talking about getting together in a support group with a support group, theme, and that also is something which has been shown to help. Now, we're going to come back in a second. You're going to share with me the things that you want to consider and not. Exercise has been shown time and time again to help with mood, and many of us during COVID have just stopped exercising. I'll admit that I have. But if we can find ways of exercising despite, it helps with mood. Let me pause here for a quick second. Do any of these things strike you as interesting or not so much right now? Would you consider talking to a counselor, for example?
Yes.
So we should try to find you someone, telemedicine, that you could connect with to process, just to kind of share some of this, because you spend so much time outwardly helping others and coordinating things. We need some quiet time where you just say, hey, look, this really sucks, or hey, this is frustrating, and let you process. So I'll take that as a homework assignment to try to help you find somebody. And it's kind of a weird world, but they don't have to be in Florida. They could be anywhere since it's telemedicine.
I have actually just taken rides to the Everglades and just parked somewhere and watched the wildlife around me, and that's how I decompress for a few hours. And it's good. I mean, other people go to the ocean and they just sit by the beach, but I'm not an ocean guy. I'd rather do the Everglades. So I'd rather swat flies. And
people in Ohio, we just dream about the ocean and the water.
Okay, gotcha.
Now, let me ask you also, we talked about exercise, and it's easy for me to sit on my duff and waggle fingers and tell you to exercise. But if I could trick you into doing even like 15 minutes of yoga every morning, any type of movement has been shown to help with mood. Do you think I could get you? Okay.
I walk. All right. Yeah. I didn't bring up the exercise because that's something I'm already doing. But,
okay.
Listening to or speaking with a trained person, I think would be probably number one for me right now. And it's something that I do not do.
Okay. Let me throw out one other idea just to bounce it off of you, because we have excellent evidence that medicines can help with mood big time. And this is true in the general population. It's absolutely true in MS. And I'm always, when I start a medicine, looking for a twofer and a threefer. So one might consider a medicine to help with mood, but it also will help with energy. And I'll throw out a medicine. Have you ever taken Wellbutrin before?
No. I don't do medicine. I hate medicine.
Well, but
I don't even like taking Tylenol.
Here's the thing, Stu. If it's bad enough, you'll consider it with me. Right?
Yes.
And we're not going to do anything that you don't want to do ever, right? I just want to bring the option to the table. So Wellbutrin is a medicine. It's a pill once a day in the morning. I find it to be very activating. It doesn't impair sexual function. It doesn't cause weight gain. So those are relevant to me. And not just helping with mood, but it also helps with energy. So I know you're not a big medicine fan. Just write down the word Wellbutrin and maybe peruse looking at it. If down the line we want to consider using something to help with mood, that might be a good one, given our earlier conversation about energy levels.
Yeah, I actually know people using Wellbutrin, and people that are close with me, and that they've brought that up to me in the past as well. But I had always thought that that class of medication, that you have to build up to a certain level, and that you're not allowed to just stop. And that's why.
So if we're going to start an antidepressant, we have to agree on two things, I think. Number one is we have to agree, barring side effects, to try it for about a month, because it can take like 4 weeks or sometimes 6 weeks for it to start working. And the reason I bring that up is if you're like me and you take it for 3 days and it doesn't work, I'm going to stop it. But here you've got to keep on for at least a month. The second thing is that when we find that it's working, Stu, so if you notice, wait, I'm feeling better, we need to take it for at least 6 months or you'll risk having a rebound. However, after 6 months on the therapy, we can have a legit discussion about bringing it back down. So you're right, there is a little bit of a commitment, but it's a 6-month commitment to trying to figure it out. Now, do I want to do that? Well, not if you don't think it's necessary. I just want you to know it's an option. So maybe for now, we're going to leverage the Everglades. We're going to leverage walking. We're going to try to find you a trained listener, and then we'll just double back and talk about if a medicine has a place or not.
Sounds good.
All right, deal.
Sounds good. Okay, next, my gait. Now, yes, I have some major ankle problems, which, I wear special braces for on my feet now, but my feet and my legs don't want to go in the same direction. That's the best way I'm going to say it.
Are you falling?
Yes.
How often are you falling?
Not that much, but more than I want to be.
Okay. Do you notice a pattern to the falls? For example, is it mostly in the bathroom, or is it mostly getting out of the car? Is there any pattern at all?
Yeah, when I turn a corner.
Okay. All right. Now,
So what's happening is that balance-wise, I'm seeing one thing and my body's doing something different.
yes, you kind of, yeah. So there's a couple things that we can do about that. And we need to take falls seriously. The last thing on earth I want to hear about is you fell and cracked a hip. I mean, that's a really, really bad day. And when we think about it, there's a couple things that immediately come to mind. Number one is, when's the last time that we did some physical therapy focused on balance and gait? Has it been a minute?
A few of them.
Okay, all right. So you tell me that you like walking, so you're not opposed to doing some ambulation. If I could hook you up with a physical therapist to give you some exercises, you can then integrate them into your walking routine. And
yes.
You're a pretty dedicated guy. If we can just teach you 4 or 5 balance exercises, that will get the ball rolling. And
Yeah.
you know the expression, you can't teach an old dog new tricks? That's false. And you can teach humans at any age new things, and you can retrain the nervous system at any age. And so
fortunately, I have, sorry to cut you off. So fortunately, I have all these people that do things for us. So I already had Gretchen to call about doing that. So
she's an amazing resource. What I'm asking you to do is to commit to a program where we're going to take a look at your balance and gait. We're going to come up with a couple safe exercises that you can integrate into your exercise regimen.
Okay.
If you wanted to get started, if you go to my YouTube channel, I actually have a couple videos I made on gait and balance. Just to get your juices flowing, check those out, and then see if any of them kind of sound like something you want to try. The other thing is that with practice we can work on it. Now, when you're turning and falling, if you think about those events, are you holding something? Are you on the phone talking? Is it just that you're walking down your hall and everything's quiet?
It's not just okay, so that's twofold actually. One is yes, I could just be walking and I'll there are times I've been out by the pool and I turn too quick and it's like, whoa, almost fell in the pool, and don't want to do that. I have my cell phone with me.
Yeah.
Or I could just be out in the yard and something just catches my attention and I turn too quick and boom, down I go.
So these are dual tasks.
Usually when I'm walking and making a turn. All right. But the scary thing is that it also happens at times when I'm driving. So I may turn too quick left or right, not using my mirrors, but going to just actually look. And I feel like when I'm going that I'm still going in that direction.
Got it. So there's a couple things that we may need to dig into, right? And one of the things that I want to bring to the discussion is occupational therapy. Yeah. So occupational therapy can actually do driving evaluations, and I find them to be very, very valuable. These guys will actually put you in a car and they'll drive with you in a car, and they can come up with adaptive measures. So that's something that, it's twice now that we've talked about some concerns you've had behind the wheel, and I want to make sure that you're safe, right? And so that's something that we can buttress by using occupational therapy. The second thing is, going back to the PT comments, there's a special flavor of physical therapist called a vestibular PT.
That's right.
And they can do things like desensitize dual tasking. So sometimes you'll see they'll have someone walking down the hall, sitting there turning their head back and forth, and what they're doing is they're helping retrain your brain to being used to do that. Yeah. We may really find value in sending you to a course of vestibular physical therapy, Stu.
I did that a few years back, and it did not work for me. And the guy told me that my follicles are going the wrong way in my ears.
So, it's not unheard of that we might find something different if we look again. Sure. Let's start with looking at those YouTube videos. Let's start with working with Gretchen, who is brilliant. I want you to be really cautious. And I'm also hopeful that if we can trick you into being more awake, some of that's going to ameliorate. But I still think there may be a role for some vestibular PT.
Sure, thank you. I would love to continue going on with some of my questions here and my things that I find wrong with my body, but I'm finding out what a freaking mess I am. My
Ah,
gosh.
well, I think there's 2 points. Our whole goal is to make you the most awesome you possible despite having MS, right? And that doesn't mean that you don't have things going on. It just means that we figure out how to game them out despite them.
Yeah,
And I think that, sometimes when you sit here and talk, we identify a bunch of stuff. Okay, I get that. But then we have to say, okay, well, what are we going to do to improve upon them? And,
yeah, but I feel like I'm going to be John Belushi. You want to put me on stimulants and depressants all at the same time, You want to do uppers and downers. I mean, I'm going to be in trouble here.
no, we're going to be very selective as we talk about all these options. I mean, right now we've agreed to take no medicines. But you have agreed to read about a stimulant, and you have agreed to read about Wellbutrin, and so that's gonna be our next conversation. You may never end up doing that. I'm just simply sharing there are tools out there that we could leverage if we need to.
Okay. All right. Yes, we can do that. L-carnitine. How do I spell that one?
Levo,
No.
Levo, carnitine, carnit, I-N-E, levocarnitine. Or sometimes
Okay.
you'll see it under L-carnitor,
No,
Cartitonr, carnitor.
carnitor. All right. I'll get it from you. I'll get
Yeah,
it from you. No problem.
just
All right.
try it.
I will.
So
In fact, somebody even just wrote it out in the queue thing that there's pick up L-carnitine at Whole Foods. There you go. All right,
nice.
cool. Thank you for that, Lisa. Um, blurred vision. So I have, I'm getting it a lot more frequently than in the past. And it's not necessarily it's not when I'm looking at the laptop. I mean, that I could understand, get away from it for a little while. Maybe my eyes are getting tired, but it's happening in, just out and about anywhere. I'll just feel like that I'm getting, and I know what that is also. I feel like I'm getting like a piece of plastic over my eyes. And I do get that when I'm in very hot conditions. I understand that. But what about when it's not very hot? What's causing it at that time?
Are you seeing double, or just the images aren't crisp?
So sometimes it's never double. I'm getting blurred vision, and I'm getting other times when it's like there's a piece of plastic over my eye, and I'm like having to, or a film in my eye, and I'm trying to, wipe out the film.
Is it
Right.
mostly in one eye, or is it always in both eyes? It's mostly in your
Always
left eye.
Yeah.
Is that an eye where you've had optic neuritis in the past?
I don't remember which eye I had optic neuritis in.
So you live in a place where there can be big fluctuations in temperature, and it can get really hot. And also, as one is involved in day-to-day activities, we raise our core body temperature, and in both situations, we can short circuit old damage.
Right.
And so, one of the things that I think about is, are we unleashing? It's called Uthoff's phenomenon. Where you have a reemergence of some loss of vision in the setting of I'm overheated, or I'm overtired, wink, wink, or
Right.
I'm under significant psychosocial stressors. If you
Right.
have blurred vision and you rest, or if you cool your body, does it get any better?
Yes, but that's what I was talking about when I'm in the heat, I know about Uthoff's. And I was wrong about the left eye because it's happening in the right eye also. And
Okay.
the reason why I'm bringing that up is because I had cataract surgery a year ago in my right eye, and it was perfect vision until recently. It started getting blurry again. So now I'm wondering, though, if it's maybe a faulty new lens that they gave me.
Well, so, there's a couple things that we can do. I mean, it's probably worthwhile to have our colleague, the ophthalmologist, take a look and just
Sure.
make sure that there isn't a mechanical issue that's cropped up, because, sometimes nature can be too generous, and you can have MS and, a problem with a cataract surgery. So we want to cross that off the list. That's very, very relevant. At the risk of you telling me that I'm throwing too many medicines at you, you're very well aware that there is a medicine that helps with heat sensitivity and motor fatigue. If I ask you if you want it, you'll tell me no. I just want you to know that it's available. And there's plenty of patients that find that if they take this medicine, 4-aminopyridine and Ampera, that it can help with that. Also, as we get back to the heat, have you ever messed around with a cooling vest?
Yeah, it makes me look too fat.
So
And now after losing 25 pounds, I don't want to look heavy again.
Fair. But those are things that can be very, very helpful in trying to cool the body temperature. I guess for starters, let's make sure that there isn't an eyeball problem and that we're dealing with an MS problem.
Sure.
And then we can start to game out what we do about it. When's the last time that you actually had like glasses checked?
Not too long ago.
Okay, all right. So, let's have the ophthalmologist do a once over and tell us, no, Aaron, it's not the surgery or the procedure.
Sure.
And then will you do me a favor? And I want you to pay really close attention when you're noticing the blurred vision and you're not overheated. What I'm particularly curious about is, what are you doing? Are you up walking aggressively? Are you in a moment where you're really, really agitated? Sometimes folks will get a neurological symptom when they sort of get hyped up.
It's more when I'm driving.
Okay. All right. Again, I want to do everything we can to make sure that you feel confident and safe when you're driving.
Sure.
Let's start. If you haven't seen the ophthalmologist in a minute, let's start there just to cross that off our list, and then we'll double back. I suspect that when we work with a vestibular PT, or if we get involved in some of this driving stuff, we're going to flesh a lot of this out together.
Sure. So you mentioned a medication before that I only know for it to be used for walking and for some other issues, but when you brought it up, the 4-AP, can you say what that was about again?
Yes, absolutely. So 4-aminopyridine, or the brand name in the United States is Ampera, is a pill that you take twice a day. And it works in only about a third to half of people. And we're not smart enough to know ahead of time who's going to respond and who isn't. So barring side effects, we give it to you twice a day for a month. And at the end of the month, you're either going to say, wow, like a Lazarus effect, or you're going to say, I'm not sure if it worked. And if you say, then it didn't work. And what it'll do is it'll buttress against any form of heat sensitivity. Now, in the clinical trials, Stuart, we studied walking speed because it's easy to study walking speed. So it was really easy to demonstrate people on this drug walked faster than the folks that weren't on the drug.
Right.
Very few of my patients want to walk fast. We want to walk long, and we also don't want other heat sensitive issues. So I'm hypothesizing that you're short-circuiting your vision at times when you're overheated, and it's very likely this medicine could help with that. I'll give you just a funny example. A patient of mine, I put him on 4-aminopyridine because he gets overheated and then gets weak. And his wife said, by the way, you can never take him off his 4-aminopyridine. It actually helped with heat-sensitive erectile dysfunction. So in that gentleman, it helped in the bedroom. So here I'm wondering in you whether it would help buttress against blurred vision when you get overheated.
Well, maybe, but then I'd be walking around with wood all the time. Then it sounds like.
I love it.
Thank you. All right, so we're going to definitely look into that one though as well. And then the headaches. The headaches I've spoken with you about time and time again. You gave me a medication recently, which I will say definitely helped. So I just wanted to let you know that, and for anybody else that's out there, I have problems with migraines, and Dr. Boster gave something to me that, it's really not a preventative.
It's an
because the migraines don't happen to me all the time, but it really nipped it in the bud within 40 minutes after it really came on. I get the ones that begin like an ocular, where you're seeing like in a kaleidoscope, all these prisms all around you. And it's really a weird sensation. And then after that's gone though, that's when I know though that I should take that pill, because when that dissipates, then the headache comes on, and the headache is like somebody wants to take a sledgehammer and bang the crap out of your head, right?
So you said it beautifully. We're talking about an abortive agent to break a migraine, and oftentimes we inappropriately wait too long to use those medicines. So right. It's not uncommon. Someone will say, well, I'm just going to wait for the shiny lights to go away and see what happens. Well, we know what's going to happen. You're going to have a wicked migraine. So when you start to see the scintillating scotoma, that's the doctor word for those shiny lights, that's your trigger to take that medicine to see if you can break it. And I always want you to do it with a big glass of water if one's available, and with a cup of coffee to help with vasodilation, to help with the migraine. I'm glad to hear it's working. Let's make sure that we're not doing it more than twice a week. If you're finding that Good. If you do it more than twice a week, you can start to develop some other problems with it. But I'm really glad that's working. Good. So yay.
Great, 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 great. By the way, the guys like my wood joke, so I have to just say this.
Yeah, suddenly all these guys are going to be asking for 4 AP for the wrong reasons. I love it.
Right. Exactly, exactly. So,
All right, what is on your list?
well, nothing else is on my list, but we've told so many people that we're going to be doing this program ahead of time that we did have, a couple of pages of notes that came in for me to ask you, and I weeded through some of it, and some of them I felt were extremely important. So I want to hit those first. I know we don't have a lot of time with you today, and I don't have a lot of time. I have to prepare for a program we're doing tomorrow. That's why I'm here in Central Florida. We're doing a hybrid program, which is like we did in Columbus, where with you, where we have X amount of people in the location, and we're also doing it virtually. So, that's, again, one of the reasons why I'm here.
Before we switch to those questions, let me just, in the spirit of telemedicine, do two things real quick. One of them is I want to do a quick screening exam. The reason is I want to help people understand that this is not just chit chat and talking, that there's some stuff that we can sort out. And then the second thing is I want to review an MRI with you just very briefly, all right? And it's not so much to go through specifics as it is to share that this is very viable. So humor me for just 5 more minutes, pretty please.
Yeah, one moment. So one of the questions, coincidentally with what you were just saying, is how are scans reviewed via telehealth, and how are visual assessments handled on regards to weakness and stability? So I'm glad you brought up about the MRI, because that will mean that I don't have to ask that question.
Awesome. So let's start by reviewing an MRI. Now, the program that you and I are using right now is actually slightly different than the one that I use on my day-to-day clinic. And so it changes the way that we do it. But nonetheless, in both cases, I share my screen. So before I show you these MRIs, these are not Stuart's MRIs. I've pulled up another MRI on purpose, and I've de-identified it, so we don't know who the person is. But it is someone with multiple sclerosis. And I'm going to share it with you just to kind of demonstrate what we could do. So let's try that now. I'm going to share my screen, and hopefully you can see what I can see. And so, Stuart, are you able to see okay with what we've got in front of us?
That's great. It's great.
So on the left-hand side of the screen is your brain from the top down. All right, so you're looking down on top, and if you can see my cursor, you got eyeballs at the top, and you've got the nose, and then on either side you have your ears. Now, on the right-hand side of the screen, this is that same you from the side, okay? So you can see your nose and your lips and your jaw, and you're looking to the left. Now, I'll be talking to you on the left, and can you see the screen moving there, Stuart?
Yes. Just remember, everybody, this is not my head or whatever, because that nose looks too good for me.
Yeah, this is an example of someone with MS, but it's not Stuart's actual scan. And what I wanted to show you is, as I talk to you on the left, you can see that green line move on the right, and that kind of shows you where we are in space. So with this setup, you and I are able to go through MRIs rather exquisitely. And for example, whoops, that's not very nice. For example, we see this white spot right here, and what we can do is we can really try to characterize it. We can kind of look at it in 2 different dimensions. So now on the right, you can kind of see its orientation. We could pull up old scans and put them next to it and compare and see if this lesion has gotten bigger. We could switch the scan around and look at the administration of contrast. So my point here in sharing this with you is that we have a tremendous facility to discuss neuroimaging while we're doing telemedicine. And I find it actually to be very, very effective.
That's cool. All right. And as far as the, you wanted to actually do an exam, yeah.
I would love to. Now based on our discussion earlier, the stuff that I would want to do would be walking vestibular balance, which we're going to opt not to do for 2 reasons. One, I don't want you to fall, and I don't know that we can bring someone behind you to watch you. Now, during telemedicine, I would actually bring like a colleague, spouse, somebody to stand behind you just to provide what I call contact guard. But there are, well, we can. Do you have enough room where you are to stand up, or not so much?
Like in the studio, we got plenty of room.
All right, well, so let's try some things, okay? So for starters, looking straight ahead the way that you are, and you can, if you don't mind slipping the glasses off, it'll just make it easier for me to see. Looking straight ahead, close your eyes really tightly like there's soap in them. Open them up real big as if you're surprised. All right. Now force a big smile like you're real happy. Stick your tongue out for me. Now on telemedicine, I use sounds to help me understand cranial nerves. So this is kind of, I think, cool. If you want to test the cranial nerve that runs your face, all right, the 7th cranial nerve, we can test that by making the P sound. So humor me, pa, pa, pa.
Pa, pa, pa.
So the sound is normal. That tells me that cranial nerve is probably working really well. We can test the 9th and 10th cranial nerves by making the K sound, because we're going to move the palate in the back. So say ka, ka, ka.
Ka, ka, ka.
I really want you to hit that K really hard, Stuart. Ka, ka, ka.
Ka, ka, ka.
All right. And then the T sound helps us test the tongue for the 12th cranial nerve. So ta, ta, ta.
Ta, ta, ta.
Now you put it together for me. Patika, patika.
I think we have a neighborhood here like that. Pataka, 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 pataka.
Yeah, sounds solid. So again, looking straight ahead for me, with just your eyes, look far left. All right, and then look far right. Okay, relax for me. Shoulders way up like this, if you would, sir. All right, just let them fall. Can you give me a Superman impression?
Absolutely.
Now flip your hands upside down like you're going to hold a pizza box. All right, try to open your palms flat and hold them perfectly still.
Like
All right, eyes closed, turn your head left to right like you're saying no. All right, make some pointer fingers for me. Bend your elbows, do a little dance. Go the other way. Make a little love. You don't have to do that part. All right. Give me some of this though. Now bring your wrists like this and bring your hands in and tap fast. Can you just isolate one hand and give me some tapping like this? And then I want you to be fancy. Just one. Okay, let's try it over here. With the other hand, give me some fast tapping. Okay, and then let's be fancy. A little slower over there. Try it, let's do it like this. Okay, make a pointer finger with one hand. Touch your nose, camera, nose, camera. And let's switch to the other hand. Nose, camera, nose, camera. Okay, now before we do this next piece, do you feel safe and have enough room to stand up where you are?
Yeah, we just both got to mask up, that's all.
Okay, all right. Here, in the spirit of camaraderie, we'll all do this together. So go ahead and sit back down for me. No, I'm just joking about that. Go ahead and sit back down in the chair, and I'm going to have you stand up in a weird way, okay? Cross your arms like I Dream a Genie, and with your arms crossed, stand up for me. Beautiful. Okay, now bring hands and feet together like a soldier. And Bill, if you come behind him, just God forbid he gets unsteady, that you catch him. Stuart, do you have your balance?
Yes.
Okay, eyes closed for me, partner.
They're closed. Wait, let me turn the camera up. There you go.
Eyes closed. Eyes open. Okay. All right. Now, do you have enough room that you could walk away from me and walk back, just so I can? And I want you to be very careful, Stuart.
Yes.
That's impressive. You're walking backwards. Come back towards me.
I practiced the backwards.
I'm impressed. All right, go ahead and have a seat. You know, with Bill there, we could spend some more time, drop the camera down, and actually do some provocative testing. But I don't want to do that just right now. But thank you, and Bill, thank you for your help.
Thank you, Bill.
In keeping you safe. So, you know, my point here is there are some things that we can see on camera. Does it recapitulate an entire in-office neuro exam? No. Does it give us insight? Yes. You know, if we were going to wrap up a telemedicine visit, I'd want to put a plan in place for when we're going to talk again. Based on this visit, I'd invite you to touch bases with me in about a month, because we have a couple things that we're going to be trying out. You're going to be looking into your use of nap and how much sleep you're getting. We're going to be thinking about an energy pill and whether or not you would want to learn more about that and consider it as an option.
Right.
Very importantly, we identified that you would be interested in talking to a trained listener. And so we're going to work to try to find you someone. I've given you a homework assignment to read about Wellbutrin just to kind of familiarize yourself and as it relates to heat sensitivity and PIRA. I'm going to get you involved in some vestibular physical therapy, and then I want to touch bases in maybe, no less than 2 months and kind of see how we're doing.
Well, that's a great idea. Thank you. We
For
should
sure,
do this again. Then we're going to be doing this again in 2 more months. Is that what you're saying?
All right, I dig it. So
We'll
let's
be
jump
online to do this again.
That sounds great. Let's jump into some of those questions. I'm curious to hear what people have to say.
Okay, great. All right. So one says, I've only done telehealth with my therapist, not my neurologist. So are there any helpful tips to use for, excuse me, I've only done telehealth with my therapist, not my neurologist. So any tips would be helpful.
So
Making a list. From my perspective first, yeah. Go ahead.
That's a huge tip. So Stuart's tip is arguably the most important. Prepare your lists ahead of time. Write them all down and have your questions ready. A second pro tip, make sure that you have your device that you're using to conduct the telemedicine visit plugged into the wall and standing up on its own. What you don't want to do is be holding it in your hand, because I need you to have both hands free. And you don't want it to go down to 10% battery. So be planful and have it set up. Also, make sure that it's light. I've done telemedicine visits where literally the patient's in the dark and I can't see them. So make sure that the lights are okay. Those are not things that we normally think about when we're planning an in-office visit, but it really makes a big difference in the success of a telemedicine visit. Any other, do you want to throw out another tip, Stuart?
Yeah, well, question, the person wants to just know what's best to keep from falling, but I think that you ran through that with me as well before, but if you want to say it again.
Well, when you're in the office and I ask you to stand up, I'm right there. All right. So if there's a concern and you stumble, so the fact that you're in Central Florida and I'm in Central Ohio, if you fall, it's going to be about 18 hours before I can get to you. And so we have to come up with an alternative to keep you safe. Here, we have Bill to help you just as a contact guard. But there's been many times where I'm doing telemedicine with someone at home and we do not stand up because, we can't guarantee they're safe. So safety first, obviously.
Right. So person wants to know if they don't have a recent MRI to compare with their neurologist, how would the neurologist then be able to figure out what's going on?
So let me answer that two ways. Woo! Hold on. 2 ways. Yeah. Right. So one way is the MRI is one piece of information to learn about you. The most important way I learn about you is what you tell me. All right. Because you're a you expert. And if I can listen, I can learn a lot about what's cooking. The second way is what we see on examination. Now, today we demonstrated a facsimile of an exam, and there's things to be learned there. A third way is on the MRI. And so I simply point out that it's not just all about the MRI. That is one element that guides us or helps us. The second thing is, you're right that if you're looking at an MRI, you want to compare it to one that was done beforehand to see if there's new stuff. But there's a lot that you can learn on one single scan. If they've given contrast, does it light up? If you have a contrast-enhancing lesion, that's a brand new lesion. You can look at brain volume on the MRI. You can look at the distribution of lesions. And if the neurologist has taken careful notes and they've commented where they've seen spots, then you can get a facsimile or a gestalt of if there's change. And so there's still a lot that we can learn when using an MRI, even if we don't have comparisons.
Okay, great. So a person writes that he or she, and I don't have names, so I have no idea, they're new to the MS space, and how can he or she best communicate their needs with their physician for the first time virtually?
I think the answer lies in the notes. So, when I do a new consultative visit, one of my requirements prior to scheduling a patient is that they complete a timeline. And the timeline is literally a bullet by bullet. Back in 1999, I had this happen, and in 2000, I had this, and they list that all out. That's a lot of preparing, writing down all your questions and maybe even prioritizing them before you sit down at the visit is a key step. And when you sit down with the doctor, let them know you have a list. You know how when we sat down and you said, Aaron, I have a list? That triggers me to make sure I do credence and I look at that list. And so culturally, now the doctor's ethically bound to talk to you about the list that you prepared. So So you prepare it, bring it, and say, hey, I've got questions. I wrote them all down. I don't want to make sure I forget.
Right. So this next one, before you answer, I would like to answer because they're asking a patient's perspective, but they're interested in knowing the biggest challenges from patients' perspectives that telehealth helps overcome, and conversely, what challenges or concerns it presents to the patient. But I want to let everybody know that if you can't get to your doctor because of our current health crisis going on out there, that this is this is the next best option that you have in doing and in meeting with your doctor. So, if you ever had fears about being on the internet per se, all right, because there's a lot of people that just will not get onto any type of group call on the internet or whatnot. But this, if you actually just let yourself go one day and set up the appointment and do it with your doctor or do it with somebody else first, you've probably done Zoom calls with your family or whichever platform you're using. It doesn't have to be Zoom, but you really need to, have the confidence in knowing that whatever goes on the internet between you and your doctor is confidential. All right. And they're going to keep it that way. And it's only confidential if you keep it confidential. If you're going to go and take what you have and post it all over the internet, then it's not confidential. All right. But
That's
now
fair.
I'll let the doctor talk.
I don't have anything to add except to say that, there's a lot of things that we can work on, improve upon, game out, and sort remotely. There's a level of trust and comfort on both sides, which is needed. I think that we've demonstrated today that there's some certain things that you have to do to prepare, but it can be very, very effective. And to your point, it's very safe. So I don't want to bring someone into the office and expose them to the risk of COVID if I don't have to. And thank God this technology allows us to keep people safe while we deliver care.
Great. Thank you. So a person online named Cindy just wrote, are there any suggestions for finding a psych therapist that actually understands multiple sclerosis? I'm going to let you answer that first, but I'd like to add something to it as well.
Absolutely. So the MS community is something that we can leverage in that regard. I've been doing MS now for quite some time, and over the years, I've collected relationships with expert counselors. And over the years, I've referred them so many patients. Many of them now identify as being having a degree of expertise in the MS space. And so a short answer is ask your MS neurologist who she refers her patients to for counseling. Very likely, she has similar relationships that have developed. Another place that you can go is to support groups and ask people living with MS in support groups, hey, you're in my area, who do you recommend? Who's good? That's another way to do it. You can sort of look at National MS Society local chapters and ask them if they have resources. So with a couple questions and tapping on the MS community, whether that be another patient and support group, whether that be an organization, or whether that be your MS doctor, we can help identify some expert listeners that understand MS. Stuart, what would you add?
So I'm going to add that, we have experts speaking on these platforms, since the pandemic began, but even before that, the people that we use at a lot of our programs, especially these days, are, depending on where you live, you could either contact that person directly or like somebody like Rick Harris, who's a psychologist who has spoken at a zillion of our programs in person and virtually. He does Telemed. So, he would be a great person for you to talk to. And he's very in tune with multiple sclerosis because he sees and hears me also. All right. But no, he would be great to speak with you all. So, if you need his information, I can easily get that to you. I'm not trying to boost him up, but I am going to tell him I want a percentage of it. No, I'm joking.
Well, but the point, the important point is that you don't want to have to start your first 4 counseling sessions explaining to someone what the autoimmune disease of MS is, right, and how it can impact energy and mood. I mean, you would ideally like a partner in your psychological care that's aware of those things. And that's where talking to an MS doctor or an expert MS patient or support group can really identify those people for you. And he is outstanding. So it's actually a really good recommendation.
Good, thank you. All right, so then Another person writes that his name is Nick, has trigeminal neuralgia 24/7. What can you suggest for him?
So there's tiers to or intensities to what we do to manage this. So if you're having chronic pain, that's obviously very different than the discussion that you and I had, where your pain is intermittent and infrequent. Chronic pain, I'm going to want to place that guy on some of the medicines that I mentioned, like Tegretol, for example, scheduled 2 to 3 times a day. We may, in fact, need to use 2 or 3 medicines to dampen down that pain. And there are surgical options. There's gamma knife radiation, there's actual neurosurgical procedures. And so there's several things that we might do to try to control that discomfort. But it's categorically different than what we're dealing with during our conversation earlier, because that's not an episodic rare thing, that's a constant chronic thing. And so it changes the approach to the medicines.
Okay, thank you. All right, so another one is let's see how it works. Okay, so can nerve situations be seen for recovery and function, how they function? Is this something that could be seen off the MRIs?
So that's actually a good question. The MRI takes a picture of structure. It does not look at function. And so it's very valuable and useful, but it's not telling us how the organ functions. For example, if I took a picture of the outside of your house and I asked, are you eating dinner? I don't know. I don't know what's going on in your home. I just know what the outside looks like. And so the MRI is valuable, but it doesn't give us information as far as function goes. Now, how do we figure out about function? Well, one way is we talk to you, right? Another way is that we do testing. Another way is that we do neuro exams. So when people are in office, we do 9-hole peg tests to look at their upper extremity function. We do timed 25-foot walks. We do cognitive evaluations. We do visual tests. Those are functional tests. Another way, for example, I'll use an example of cognition, all right? Looking at the MRI, we might see that someone has accelerated brain shrinkage. That's a structural problem. But if we get neuropsych testing, we can look at the function of the brain, like how well you do with thinking in various aspects. So the short answer is no, we can't just in isolation look at the MRI. We have to use that as one piece of a bigger picture.
Okay, thanks. The person writes, what are the doctor's goals during a telehealth visit? What can be accomplished without having the patient right in front of you? And again, before you answer that, I have the sniffles, I'm sorry.
So what are my goals during telehealth follow-up? It's the same as my goals in the office. Really, holistically, I want to understand how my patient's doing. I want to understand what's new in their life. I want to make sure that they're on a disease-modifying therapy, that they're tolerating it, and that they're responding to it. I want to make sure that we're addressing symptomatic management and that we're optimizing their quality of life. I want to make sure that safety is addressed, and so whether they're disease-modifying therapy or they're symptomatic therapies, if we need to get labs, if we need to get imaging to make sure that we're up to date with safety concerns. I want to make sure that we're up to date with monitoring on MRIs, and so I want to make sure that's taken care of. I want to make sure they have all their refills. I want to make sure that they're not smoking cigarettes and that they're supplementing their vitamin D and that they're exercising as part of their lifestyle. So there's a lot of things on my end that I'm checking and looking at and making sure that I've got plans in place with each visit. And honestly, those aren't different whether it's telemedicine or whether it's in the office. The difference really becomes the coordination of setting up the Zoom call or the telemedicine call, and the fact that I can't reach Florida from where I'm sitting, and so I'm a little bit limited in what I can do on examination. That's the extent of it. The rest of it is gaming out how to win despite having MS, the same way we would if you were in the office.
Okay, thank you. All right, 3, possibly 4 questions remaining here, and that is, will telehealth continue into the future?
I hope so. I don't know the answer, and the government hasn't called me yet to ask me my opinion, so I'm waiting for that call. Oh, yes. So I think that if there's a silver lining to this global viral pandemic, one of them might be the adoption of telemedicine. And I'm sorry, I'm trying to chase this light that's in my face. So we'll do it like this. The chronic illness community, if I can use those terms, has been demanding telemedicine for decades. right? This is not a new request. It's just that now that a bunch of people can't access their doctor nationally, that we've started to leverage this technology. And I hope that it continues, because I think that it's a step up in care. It's my opinion that if I could see the patient in the office once, ideally twice a year, I can do everything else remotely via telemedicine. And I don't know if it's going to stay that way, but I hope it's going to stay that way. If I was guessing, I guess that even post the viral pandemic, we will have telemedicine as an aspect of care. I just don't think any of us right now know the extent to which it'll be utilized.
Okay, great. Next question. What should a patient have ready available for a virtual appointment? And are you able to start new patients with virtual appointments?
So I'll take them in order. You need to have a quiet space. So you don't want to have 3 kids running behind you and dogs and cats barking. You need to have good lighting. You need to have a camera which is reliable, and you need to have whatever software downloaded and ready. You need to have already gone to the bathroom. And if you need a beverage to clear your throat, you need to have it with you. So that's getting set up so that you can be successful. Because we're dealing with different time zones and nationally, I've had patients that messed up the timing because we told them 2 p.m. and we meant Eastern Standard, and they're in California. And so just clarifying those important details. Stuart's mentioned twice, and he's spot on, that you need to have your notes ready. I want you to have your list of medicines updated. And if you don't have a medicine list, grab your medicines and bring them next to you so that as we talk about them, we can look at each one of them. As I pointed out earlier, you want to make sure that your camera is not in your hand. You want to make sure your camera is fixed so that you have your hands free. And ideally, you want to have enough space that you can stand up and move around so that I can see you. And so those are other things that we need to be doing. And you know, just like any other telemedicine visit, if you benefit from having a village member with you so they can listen and ask questions and take notes, then bring them with you on telemedicine. Something that's really cool is they don't need to be in the room. We can have them dial in from another location. So sometimes I'll have a friend or a spouse or a colleague jump online. And so we'll have 3, it looks like, you know, the Brady Bunch. Now, as far as new patients, because of the emergency laws that have liberalized telemedicine, we are legally allowed to see new patients on telemedicine. And I have done a lot of new telemedicine visits. I need the family to mail me all the MRI discs prior to the visit because I look at all of them. I need them to mail me all of the laboratories and all of the old clinic notes beforehand because I look at all that before I see them. And that way, when we meet, and I do a 2-hour new consultative visit, Stuart, it's a pretty a long visit. I want to make darn sure that I have everything ready so we really, really leverage that time successfully. And I think that we do a good job. I think that it is doable to do telemedicine new consultative visits. I've been doing it now for months and months, and I think it's working.
So with regard, though, to patients mailing, I'd rather that they don't mail that stuff to you because the mail's so screwed up lately or whatever. But what if they could send it to you by like FedEx or UPS or something with express mail, something where it could be tracked at least?
Correct. And so when I say mail, I mean getting it to me. But you're right. I mean, a lot of times we're using UPS tracking so that I know where it is and they know where it is. There are increasingly more and more options for looking at imaging electronically. And at my center, we actually have, we've signed up to some special softwares. So you may be able to virtually push your imaging to me just through the computer. And so some of the patients, that's how we're pulling up their scans.
Gotcha. Is there any, I was going to say, is if there's any way that somebody could use like a Dropbox or something like that to get it to you, can they upload that? Can they put their files, their scans in a Dropbox? Or I don't know if it's large enough to get. So
it's not necessarily large enough, and there's concerns about HIPAA compliance. You know, and so we have opted to use softwares like Ombre. These are softwares created to house neuroimaging, so it can be sent from a hospital system, then I can pull it up, and it's done in a secure fashion, so there's no risk of someone else seeing your scans or getting a hold of the discs.
Okay. And person writes that can they start an actual relationship with their doctor on telehealth, or do they need to be an established patient? And I think that's the same basically as what you just answered.
There are patients that I have established care with, I have diagnosed, and then started on a disease-modifying therapy, and I've managed attacks, and I've never shook their hand. Now, you might throw stones at me and think that's weird, but I'll remind you that we're dealing with a global viral pandemic, and many of these patients didn't have access to subspecialty care otherwise, where they live or nearby. So is it ideal? Well, maybe not. Do I look forward to meeting them in person? Well, heck yeah, I do, when it's safe. Do I feel like we're providing excellent care? I really do. And I'm very proud of that. And I'm excited for the partnership with my patients. And it's kind of a crazy but exciting option that we can help, even though we haven't met face-to-face physically.
Great, thank you. We have 2 questions remaining, I think, but before that, Dina wrote in that she wanted to thank, she says, you're both doing great, thank you. Getting to watch today was awesome. Would like to say thanks to both again. Tell Aaron, great job. You are both a wonderful team. Thank you, Dina. We do know that. We know we're a wonderful team. That's why we want to do this more and more. But yeah.
Give me a high five, Stuart.
I wanted to put myself on the line today. Exactly. I wanted to put myself on the line today and just show people you don't have to be open with the whole world like I was doing. Like, again, I have to treat myself as an open book. Of course, there are other things that could be wrong with me that, you know, Dr. Boster is not the doctor for that, so I'm not going to bring those things up. All right. And I may not bring that up virtually anyway. So, you know, it's just other things. But the idea is that I wanted everybody to know that you can feel comfortable speaking with your doctor about this. And a person now is writing, does it matter what state we live in if we wanted to see Aaron, have Aaron as our medical whatever? You could tell them.
So in the COVID era, there are laws in effect that allow that to happen in any state in the United States. And we anticipate that when the COVID era ends, those laws may change or reform. We don't know yet. So the answer to the question is today, yes. Today, you can establish care with a tertiary subspecialist. It doesn't need to be me. It could be anyone that's doing this. And it doesn't have to be in your state. But when the world starts to go back to some degree of normalcy, we have to see how that shakes out.
Okay, thank you. Here's a good question. How do you start infusions with a new patient remotely when a new patient is starting remotely at home or at a local infusion center?
So you need a really, really long IV line. No, I'm joking. And so it depends on the type of therapy. So there are certain therapies where I see someone virtually, and I'll give a real life example of a gentleman who I met on consultation in Texas. And he has subsequently flown to Columbus, Ohio during the pandemic, and we've treated him with therapies, IV therapies, and then he's flown home. And so that's an option, and that's an option which is viable under normal circumstances, and it's viable even now. So that's one way to do it. Another way to do it is to partner with a local institution. So to partner with a local neurologist or a local infusion center, and then to try to have the administration of whatever that infusion therapy is done local to that person. There are ways to do it. There are other therapies that are not infused therapies that can be prescribed and taken by pill or shot that you give yourself. So there's a lot of ways to game that out. And one of the complexities of telemedicine, just one other element is, okay, we've identified your therapy. Now we have to figure out where and how you're going to receive it. But those are surmountable. I've been accomplishing that with success over the past, 6-8 months. It works.
Great. Okay. Last one, I believe. Can you recommend okay, no, I can't recommend. All right. So somebody wanted to know specifically to recommend a psychiatrist or pharmacologist who understands the combination of meds taken for South Florida. So Lisa, I'm just going to have to say to you, I mean, Dr. Boster would say the same thing. Contact the National MS Society, since they are right there in South Florida, and, get a recommendation from them. I don't know any psychologists or pharmacologists down there. So
I think that, the National MS Society, MS Foundation, MS Association of America, there's outstanding MS patient organizations out there, and they have local chapters in your area. And so if you're not sure where else to turn, that's a great place to start.
Right. So I brought up the MS Society because they do have a detailed listing. But yeah, the MS Foundation is also in South Florida. In fact, they're based out of there, just like MS Views and News. And So, we can get that information. I can get it for you, but please send an email to me, because once I hang up this, you've already heard I don't remember that much. I do have cognitive issues, and I will forget your question. So Lisa, send it to me by email, and I'll get the information for you. I'll ask the local people and see who we can come up with for you, okay? All right. And other than that, we're done. I mean, now we could go enjoy the cool weather, right? And whatever else is happening out there these days, and there's too much crap happening, right?
Well, I want to thank you, Stuart, for suggesting that we do a follow-up and for letting us share sort of something that's rather intimate in this fashion, so that others can feel less scared.
Yes.
It's my hope that people watching appreciate that you can game out how to improve the quality of someone's life and thrive despite MS with your clinician remotely. I mean, again, you're down in Florida, I'm way up here in sunny Columbus, Ohio, and we're figuring out how to win, and that's awesome. If you're on the call and you're impacted by MS, I encourage you to consider this modality, particularly in the now. And if any of the things that we've talked about today, whether that be identifying a telemedicine counselor, or thinking about physical therapy, or thinking about a symptomatic medicine, kind of stirs something in you, reach out to your provider and tell them that you want to have a conversation. We want to help you, and we'll help you on telemedicine.
And for all those that are on here, if you wish to see how I do in 2 months from now, come on back for our next call, and you'll see if I actually listened or not.
All right. I can't wait. I'm excited as well. My name's Aaron Boster, and as always, I want to thank you for learning about MS with me. MS Views and News is an amazing organization, so if you're not familiar, definitely check out their YouTube channel, check out their website. It's a repository of some of the best information that's out there for MS right now. And as always, Stuart, it's great to work with you. Thank you.
Thank you very much. And I will also say my name is Stuart Schlossman, and I am president and founder of MS Views and News, and I am a multiple sclerosis patient, and I am here for all of you. So if you have any questions that you cannot get answered elsewhere, I will take your questions and forward them to the correct medical expert, and we'll see what we can do for you. Okay? Thank you, everybody. Dr. Boster, I'll give you a call in a few minutes, and you all have a great, great day. Thank you for being here.
Take care. God bless everyone. Bye-bye.
Bye-bye.